I've been asked to record a short lecture on anterior segment causes of reduced vision in adults for the World Sight Foundation. The lecture has been designed to be paused after each slide to allow for translation if required. My name is John Brazier. I was consultant ophthalmologist at University College London Hospitals in London, UK for 25 years and then in private ophthalmic practice in London. For this lecture, I plan to use an anatomical system to identify structures in the anterior ocular segment that may cause visual loss. We can consider the causes of visual loss coming from ocular surface or tear film as problems involving the corneal epithelium. Disease of the corneal stroma or endothelium may account for reduced vision. Moving in a posterior direction from the cornea, we will consider anterior chamber causes of visual loss, including inflammation, shallow anterior chamber, and drainage angle abnormalities. Posterior to that, we will consider the human lens, whose main abnormality is cataract. At the end, we will briefly consider the posterior lens capsule. Just a note on the structure of the cornea, which is relevant to disorders causing loss of corneal clarity or loss of regularity in the anterior refractive surface of the cornea, both of which will result in poor visual quality. The cornea is now considered as three major layers, each of which may be the cause of poor vision. The layers, along with Bowman's layer and Descemet's membrane, are shown in the cross-section in the illustration on this slide and the two slides that follow. These layers may be targeted in surgical replacement of corneal components by full thickness or lamellar corneal transplantation. The epithelium is the surface layer facing the air and consists of multiple layers of cells with continuous turnover and shedding. Health of the corneal epithelium depends on stem cells at the corneoscleral limbus. The bulk of the corneal thickness, as you can see from the illustration on the slide, is the corneal stroma. This is a tough layer resistant to physical injury. It is designed to be clear to allow light entry into the eye. The clarity depends on keeping the water content in the corneal stroma low, which is achieved by continuous pumping out of water by the endothelial cells, which are located on the corneal surface facing the aqueous humor. The inner layer of the cornea is a single layer of endothelial cells sitting on their basement membrane, which is known as Descemet's membrane. So to return to the themes in my overview, one cause of visual loss can come from the ocular surface, referring to the corneal epithelium and the environment in which the corneal epithelium finds itself. Dry eye syndrome will result in lack of brightness of the cornea on examination, along with debris in the tears. This will reduce visual quality. Abnormal eyelid position will alter the corneal environment. The upper image shows entropion, with the lower eyelid rolled inwards, so lashes touch the cornea, causing long-term abrasion of the corneal surface. The lower picture shows a patient with right facial nerve palsy, so attempted closure of both eyes fails to close the right eye, leaving some of the cornea exposed and not regularly moistened with tears. Lastly, the epithelium may be damaged by chemical injury or viral disease. Corneal disease or injury may result in loss of clarity of the corneal stroma or irregularity of the front surface of the stroma. This irregularity has the optical effect of the frosting of glass as used in bathroom windows, so the eye cannot form a clear image. One common condition is Fuchs endothelial dystrophy, in which the natural decline in endothelial cell numbers in life is accelerated, so corneal function fails at the age of 50, 60 or 70. In this condition, reduced vision is due to loss of clarity of the corneal stroma, along with hazing of the epithelium, as seen in this picture. The corneal stroma may be abnormal in other corneal dystrophies, viral keratitis, or with previous chemical injuries, mainly with alkali. Fuchs endothelial dystrophy causing premature loss of endothelial cells can be identified on slit lamp examination by presence of corneal guttata, thickening of corneal stroma, and epithelial edema. Bear in mind that endothelial cell loss always follows cataract surgery, and corneal decompensation with lack of clarity of cornea may result. This causes what has traditionally been called pseudophakic bullous keratopathy. To move on to the anterior chamber, eyes with shallow anterior chambers are at risk of acute, subacute or chronic angle closure types of glaucoma. Anterior chamber depth can be measured, and less than 2.5 mm is the critical depth predisposing to angle closure. Anterior chamber depth and volume can be assessed more accurately by OCT imaging. Content of the aqueous humour becomes abnormal in inflammation with increase in protein content and presence of inflammatory cells. Where slit lamp examination is not available, anterior uveitis or iritis often comes with localized redness of the eye at the limbus called ciliary flush. A picture follows on the slide after next. Bear in mind that structures in the periphery of the anterior chamber, especially the trabecular meshwork, may cause problems. Outflow of aqueous via the trabecular meshwork declines with age, explaining higher prevalence of glaucoma with age. In addition, patients with pseudoexfoliation of the lens capsule have material deposited on and in the trabecular meshwork, sometimes leading to exfoliative glaucoma. Here are three images. At top left, the localized injection at the limbus occurring with iritis. To the right, the adhesion between pupil margin and anterior lens capsule in iritis. These adhesions are called posterior synechii. Bottom left is an eye suffering acute angle closure glaucoma with pain, redness, loss of vision due to foggy cornea, and in this case some cataract, and typically with a vertically oval, non-reacting pupil. Cataract is a very common age-related condition responsible for much blindness worldwide. Risk is increased in diabetics with inflammatory eye disease or glaucoma and after trauma. Remember that cataract surgery causes endothelial cell loss in the cornea, and consider this in preoperative assessment of cataract patients. Most cataracts are of particular types. Top left shows cortical cataract with spoke-like opacities seen against the red reflex. To the right, nuclear sclerosis is caused by compression of the cell layers in the lens nucleus with increase of refractive index and discoloration. In this case, the lens nucleus looks greeny-yellow, but it can become brown, red, or even black as the process continues. At lower left is the granular opacity on the posterior capsule in posterior subcapsular cataract. This slide lists some of the visual symptoms reported by cataract patients. General poor quality of vision is common. Poor vision at near or distance, glare in sun, or with street lights and headlights. Occasionally patients report multiple images from one eye with cataract, and this needs to be carefully distinguished from double vision, which is caused by an extraocular muscle palsy. Lastly, I just want to touch on the subject of posterior capsular pacification, or PCO, which can follow any cataract procedure leaving the posterior capsule intact. This can be phacoemulsification with lens implant or small incision extracapsular surgery with lens implant. The image here shows irregular regrowth of lens cells across the posterior capsule, causing loss of reading, vision, and glare symptoms. The rate of PCO resulting in representation of the patient is around 10% per year after surgery. Few patients return after 10 years with posterior capsular pacification, although many cataract patients will have died 10 years after their cataract surgery. Peak time of presentation with recurrent visual loss due to PCO is 2 to 4 years after surgery. Treatment is by YAG laser capsulotomy. So to sum up, we have used an anatomical system to consider structures in the anterior segment of the eye that may cause visual loss. These causes include problems of ocular surface, corneal epithelium, disease of the corneal stroma or endothelium, consideration of content and depth of anterior chamber, cataract and posterior capsular pacification after cataract surgery. Thank you very much for listening.